Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the NARM Training Institute. I'm your host, Sarah Bueno, and I'm delighted to have you join us today. Hey, Transforming Trauma listeners. If you're a licensed mental health professional working with complex trauma and you're interested in learning the neuroaffective relational model, we're excited to share with you that there are 2 upcoming NARM therapist trainings starting in January 2022. One of these trainings will be offered in an online format, and the other will be offered in person in San Francisco, California. This Level 2 NARM therapist training is designed to support mental health professionals who work with clients or populations dealing with complex trauma. Being trained in NARM, one of the first clinical models specifically designed to address ACEs and CPTSD, supports therapists to learn how to address the long-term impacts of adverse childhood experiences and complex post-traumatic stress disorder. The NARM therapist training will be taught by NARM senior faculty Brad Kammer and a team of experienced NARM training assistants. You will learn a comprehensive developmental framework and clinical approach. As you're learning and integrating NARM, you will receive individualized support from this team of skilled, passionate, and supportive trainers. If you're interested in this training, we encourage you to register now to reserve your spot. For more information and to register, please visit www.narmtraining.com/schedule. We look forward to you joining our growing international NARM community and are inspired to work with you to bring NARM to your clients and communities in order to transform trauma. Today's interview is a facilitated conversation with Dr. Lissa Rankin and Dr. Larry Heller. Lissa Rankin, MD, is a mind-body medicine physician, author of 7 books, the founder of Whole Health Medicine Institute, and a mystic who researches radical remission, trauma-informed medicine, and spiritual healing. Her TEDx talks have been viewed over 5 million times, and she starred in 2 national public television specials, Heal Yourself, Mind Over Medicine, and The Fear Cure. Lissa's interest in the link between loneliness and disease led her to spearhead her latest project, Heal at Last, which is a nonprofit organization that aims to bring effective trauma healing and spiritual healing methods to anyone ready for the deep dive of healing. So please enjoy our conversation with Dr. Larry Heller and Dr. Lissa Rankin. Hello, Lissa Rankin. Welcome to Transforming Trauma.
Thank you. I'm happy to be here.
Yeah, and we are being joined with Larry today. I'm so excited to hear the conversation between you two. Lissa, would you mind introducing yourself a little bit?
Yeah, so I am Lissa Rankin, and I'm trained as an OBGYN, so I have a very sort of traditional and conventional academic training. My father was a doctor, and I was raised kind of in the church and in academia and practiced as an OBGYN until 2007. The brief history is that I experienced now what many trauma therapists are calling moral injury, that's often used as a way to describe returning war veterans, of just kind of knowing that there was more to healing than I was taught in medical school and feeling like, if anything, I was potentially causing more harm. I was not healing and I was possibly harming, and I just couldn't reconcile the inner turmoil around that. And so I've devoted the past 14 years to studying radical remissions, trying to understand why some people have very unusual cures from seemingly terminal or chronic or life-threatening medical illnesses. And that kind of led me, I wrote a book called Mind Over Medicine that came out in 2013 that was sort of based on the science of my understanding of that. But a lot of what I was finding kind of didn't fit. It kind of didn't fit in the world of science. So, I was able to come to a lot of conclusions about psychoneuroimmunology and the ways that our thoughts, beliefs, and feelings affect the physical body, and how we as patients or we as doctors can optimize helping sick people have optimal outcomes. But there was a limit to what I was able to prove with science. And I sort of encapsulated that in what I call the 6 steps to healing yourself, which I started a training program called the Whole Health Medicine Institute, which is a training program for doctors. And now we have a lot of therapists doing it as well, utilizing that method and also exposing them to 30 other faculty members, of which Larry is now one of them, to kind of show people what should we have been taught in medical school that's beyond sort of nutrition and the more sort of wellness industry. The things that are related to healing that are more in the realm of consciousness and energy healing and shamanism and now trauma therapy, because I ended up sort of the sequel to Mind Over Medicine. I spent 10 years traveling the world working with, Balinese healers and shamans in Peru and Qigong masters from China. And all roads ended up leading me to trauma therapists, because what I realized in large part was that many of these kind of energy healers and shamans were treating trauma, but they were often doing it badly. And yet they were meeting a huge need that was not happening in conventional medicine. And it often also wasn't happening in conventional psychotherapy. And so I sort of wound up with like the unicorn therapists. Like I wound up with the people that were doing the cutting edge trauma therapy with, Richard Schwartz in the internal family systems world and Peter Levine in the somatic experiencing world and Larry Heller in the NARM world and, the energy psychology world and advanced integrative therapy and emotional freedom technique and places like that. And I started recognizing that anecdotally, at least, a lot of therapists that were working in that world were saying, yeah, when I treated this person's core developmental trauma, their cancer went away. That got my attention. What? Their terminal cancer that the doctors had given up on and they were basically getting palliative care and their cancer went away. So I had a big sort of shift in the area of my research, more towards like, well, all right, if energy healers are having this big impact on people in this mysterious way, is there a way to make it less mysterious and to do that more safely with a more trauma-informed approach and more ethics? Because I was bumping into a lot of ethical issues in that world as well, especially after the Me Too movement and Black Lives Matter and a lot of these social justice areas. There were big problems in the world of like gurus and their medical treatments and such. So that sort of landed me here. I'm happy to be here.
Thank you. And Larry, I imagine hearing all of that, you probably already have either questions or comments. So I'll let you have the floor.
Well, questions, comments, and observations. One of the things that I've appreciated about your work, Lissa, is that it remains scientifically grounded, but very open to alternative, and I don't even like that expression, but non-traditional, non-Western methods of healing, as well as to a spiritual dimension to the whole process as well. So from my own different direction, I've also integrated these kinds of dynamics because actually you and I haven't had the chance, we've talked on several occasions, but healing in general, not just through trauma healing, but all aspects of healing has also been my lifelong passion. I've enjoyed, and there's been common ground where you and I have met in many areas on that path, I think. So
yeah, it's been quite a journey. And certainly one of the things that I found in my sacred medicine research was that, I was kind of talking to people that would belong in different silos in academia, right? So I'm talking to the mind body medicine people kind of in the medical school. And then I'm talking to trauma therapists who would be maybe in the psychology department, right? And then I'm talking to, I don't know where the shamans would fit, like the anthropology department. And I'm talking to the biofield scientists who are, in the sort of biology department or the quantum physics department, where they're looking at the sort of science of some of these things, or people like Bill Bankston, who's doing hands-on healing on mice with cancer and curing cancer with hands-on healing. Like, I don't even know where he fits in academia, but he's a PhD and a scientist. And then I'm sort of in the divinity school talking to the gurus of sorts, the spiritual teachers who are doing healing work in their own way. And none of these people are talking to each other. Like, they're very siloed, which is why when I sort of had been interviewing and serving various types of energy healers and faith healers and spiritual healers and healing work that was going on at places like Lourdes and such, and I recognized that there was overlap both with the medical school and with the psychology department, I realized again that we're not having these interdisciplinary conversations in the ways that we need to be having them. And yet, if you go far enough down all those silos, they all seemed to be going to the same place. And the sort of end game of many of those silos, there's something that's universal there. And so the intellectually curious part of me that is wanting to resolve the uncertainty around how do we optimize the healing process and how do we help people who are suffering get the best possible results. Well, of course, I failed to solve that mystery. I will give that disclaimer for the book that won't come out until 2022, that I don't have the solution. But the closest thing that I came to a solution was a kind of integrated approach of the best of what we have in the world of science in the medical school and the best of the trauma healing from, the cutting edge trauma therapies. The field of traumatology is still so relatively new. That field is changing so fast that by the time my book comes out, I'm sure it will be outdated. And then the best of, what we're discovering in the world of spiritual practice and the biofield and energy systems and the way that community at places like Lourdes can participate and communicate with the individual energy system to create collective healing. And, that goes into the realm of some of what spiritual teachers like Thomas Hubel are doing. And it's very exciting because I feel like there is some there. Like I wasn't sure I could ever even write this book. Like it felt like an impossible task. But now I do feel like, okay, I've got something and I think it will help people. So that's hopeful. And I don't want to give people false hope either. So there's a lot of paradox in that world.
But I think fortunately in our field, there has been crossover. So some things, for example, I've taught pre and perinatal trauma dynamics for 30 years, but it's only really in the last 20 years or 15 years maybe that we now have scientific backup that this is real. And I quote in my book and often in my trainings, all studies that were published in the Journal of Endocrinology talking about basically pass-through PTSD. I think that was both PTSD and complex PTSD dynamics, both in like women who were pregnant and when they were directly exposed to 9/11, and all the biomarkers for PTSD plus psychological tests for that. And then seeing that their infants, their newborns, were born with the exact same biomarkers that the mothers were experiencing. So it was, one of the initial bits of scientific backup that I found for something that, I say in my trainings, I think women have known for thousands of years that what goes on in pregnancy, and here I'm talking to an OBGYN is kind of, but that what goes on in pregnancy does and can affect their developing fetus and developing babies. So it's nice that in that area and many others now, that we're getting scientific support for things that we've known for a long time, but were considered a little far out there, at least in some circles.
Right. Well, and we're learning so much in the field of, sort of polyvagal theory and the impact on the nervous system and what chronic nervous system dysregulation can do to the physiology of the physical body. So that overlap of the nervous system dysregulation caused by developmental or shock trauma and how it impacts the body is just recently beginning to hit the mainstream in medicine. Like it was wonderful that Nadine Burke-Harris, the California Surgeon General, did that fabulous TED-Med talk about the ACE score and how it impacts pediatrics and how those children that have a high ACE score then go on to develop new onset of adult onset diseases and have a significant decrease in their longevity. Even something that basic, the data has been around for a long time, but it just hasn't penetrated the mainstream in the medical world that, we need to be screening for ACEs, yes, and we need to be getting appropriate treatment for adults who have potentially ACE-related illness. But even the idea of developmental trauma, it's wonderful that right now, Bruce Perry and Oprah Winfrey have a book that's at the top of the bestseller lists about developmental trauma. And, we're having these conversations, especially because of the pandemic and Black Lives Matter and climate crisis and all of the collective traumas that we've been going through. I think a lot of these shock traumas that we've dealt with in the past year and a half have activated a lot of developmental trauma as well and sort of re-triggered and re-traumatized a majority of the population at this point. But that link between developmental trauma, I'm one of those people who has an ACE score of 0, but I can definitely relate with some of the core developmental needs in your work, Larry, and having not had those needs met and having those sort of predictable behaviors that come from that kind of developmental trauma. And so somebody like me would get lost because I look really high functioning and I'm not sick. and I have an ACE score of 0. And so I have a particular interest in bringing more attention to that population to help normalize that kind of trauma and identify that it may be a risk factor. I mean, I've been in therapy for years, so I'm glad I see it as preventive medicine, that I'm potentially increasing my longevity and avoiding cancer or avoiding fibromyalgia or avoiding some chronic pain syndrome by doing that work preventatively. But for a lot of people that already have that symptomatology, and particularly in the connection survival style that you talk about, that early, I was lucky I did get that core connection need met with my sort of enmeshed mother. But for those that didn't, the developmental trauma of lacking that, prenatal and perinatal and infant intimacy with the caregiver, and the physiological and nervous system and long-term physical symptomatology that can come along with that is something that I think it's really important for us to start to draw attention to in the medical world.
And as important as I see the ACE, the ACE research, so the original research, and then the subsequent studies that have been done since, it's so hugely important, but it's also still at this stage of its development limited in its perspective, so that individuals who had, let's say, chronic misattunement don't fit in, would register 0. But just as you said, Lissa, you resonate with some of the elements in the book. And I talk about that whole spectrum. Sometimes it's extreme, like neglect and abuse and all kinds of other extreme forms. But sometimes it's the day-by-day disordering, not being seen, not being understood, having people who provide for you your physical needs and your basic survival needs, but miss you completely emotionally, or, as you just mentioned, can be enmeshed with you in the sense, because I'm not trying to talk about your mother here, but just in general.
No, this is all true for me. This was chronic misattunement was, as it is with many caregivers and doctors and therapists and healers, right?
Right.
That we become incredibly good at attuning to everybody else's needs to our own self-neglect.
Yeah, that's the attunement survival style encapsulated right there.
Right, exactly.
So it's really important for us to continue the work and to continue expanding our understanding of developmental trauma, because, again, part of my mission has been to help people understand the distinction between shock trauma methodology and developmental trauma methodology, and they're not the same. And some things that are totally valuable in working with shock trauma are not effective, or sometimes even counterproductive in working with developmental trauma. So it's important for us to be able to make those distinctions. And, as you mentioned, just like the pandemic, for example, there are these shock traumas which tend to then trigger unresolved developmental trauma. So we have to learn how to work often simultaneously with elements of shock trauma, elements of developmental trauma, and understand the difference. So really that's my mission. And I, from getting to know you and your work and your group, I see that you're on a parallel path in your own way.
Yeah, absolutely. Well, I'm working on a book right now with Asha Clinton, who developed advanced integrative therapy, which is it's in the energy psychology family. And one of the core things with AIT is the initiating trauma, the thing that would initiate calling a therapist, right? Like a divorce, scared of the pandemic, loss of a loved one, or something like that. Illness, maybe, if somebody was aware that could be related. And then, getting to the root of what she calls the originating trauma. Because so often, for example, if somebody's going through a divorce, it's re-triggering an early loss. And to treat both the initiating trauma and the originating trauma. And then she has what she calls the connecting trauma. That's basically saying, because dad left me when I was a baby, my husband left me now, or putting those together and treating that energetically. And every method seems to have its own way of trying to get to that root. IFS has its own way. And I'm sure, I don't know as much about NARM, but I'm sure you have similar. Actually, I don't know how you do that. If somebody comes in with a current complaint, is there a sort of NARM way of eliciting what might be re-traumatizing or re-triggering an earlier one?
The interesting thing, and as Sarah just saw this weekend, is that we don't even need to elicit it. When we're working, we start with what I call the proximal trigger or the initiating trauma. And as we work in the here and now, as we do in NARM, what is unresolved from the past again and again will organically emerge as we work with the difficulties in the here and now. And so it isn't like we go on archaeological digs in NARM, like in particularly some of the psychodynamic psychotherapies. And I'm not criticizing because I'm trained in many of those systems as well. But there is a real value in starting in the here and now, and then what's unresolved, allow that to organically surface and then resolve it on that level as well.
Beautiful. Well, I have a question for you. You might have questions for me, but
Sure.
I have a question for you that came just from this past weekend. I spent the past 3 days with Chris Rutgers, who's the founder of the Trauma Foundation. And Chris and I both have a shared mission. And I know many of the founders of the models also share a similar mission, which is identifying the health equity issue and recognizing that for me, for example, I recognize that it's a huge privilege that I can pay for weekly IFS therapy for myself. And it's expensive. I pay a fortune for my health insurance and it doesn't cover a penny of it. So not only do we have a health equity issue in that, let's say we have sick people that are totally on board. They've heard me speak or they've heard you speak and they're like, okay, I totally get it that my chronic illness is related to my developmental trauma and I'm 100% bought in. I'm willing to do the painful, deep inner work to try to treat my trauma to hopefully improve some of my physical symptoms. And my insurance only covers CBT, which I've tried and it made it worse. And I can't afford to hire a NARM therapist or an IFS therapist or somatic experiencing therapist. So what do I do? And Chris also is a trauma survivor who's been able to pay for, 10 years of very expensive therapy, trying every single model out there. And so we're both tackling the problem of health equity of how do we democratize this treatment? How do we scale this treatment? Because every really good therapist that I know is booked right now, and they don't even have openings, much less the ability to take pro bono clients or, And so he's looking at it through the lens of how do we raise funds from philanthropists to pay for public health patients to get really good one-on-one treatment. And I'm looking at it from another model. I'm looking at how do we figure out what really treats trauma and scale it in a group model, maybe something akin to the way 12-step has scaled healing from addiction or healing from codependence with an addict in the 12-step model. Is it possible and is it safe? And is it effective? And can we do it inexpensively or even free, the way 12-step does it, to scale some of the ways that we work on this? And so Chris and I have spent the whole past 3 days hashing out 7 things, and maybe there's more, 7 buckets of like, okay, here's what those people need. And here's some tools that could be done in groups. And can I run the 7 buckets by you and see if you agree?
Of course. Yeah. I'd love to hear what you came up with.
All right. These are very early notes, but one of them is psychoeducation, which I think NARM is really good at. And I would say NARM also is really good at one of the other buckets, which we included, which was understanding adaptive survival strategies. And I would say, other things under psychoeducation would be things like teaching people about polyvagal theory or teaching people to understand nervous system regulation or psychoneuroimmunology and how that impacts the physiology of the body. And then embodiment, or sort of somatic mindfulness or ways to get people that are chronically dissociated back in the body would be another bucket. And then nervous system regulation, which hopefully any good therapist is addressing that aspect. Although Sarah's not so sure.
Hopefully, yes, probably not. Yeah.
Right. I mean, because of course, many of us have that attunement survival style and maybe dysregulated in our attempts to regulate, but nervous system regulation being another, and then metabolizing implicit sensations, emotions, and memories. And then for me, this was one that Chris wasn't so sure about, but for me, the spiritual dimension has been absolutely an essential resource for me, my spiritual practice, my connection to sort of what I think of as the divine inside of me. I don't think we have to even put any sort of religious spin on it at all. I mean, I think people can have a spiritual connection to a redwood tree or to a mountain spirit or to the ocean. Like it can be just nature, but that sort of transcendent or immanent divine in whatever way people identify with that. And then for me, the piece that's been really missing from a lot of the trauma therapy models is community. And this is what 12-step does so beautifully. Like I would have done much better. I would have done much better if I was able to do my one-on-one therapy and then also go to a recovery group or be with other people that were using IFS for healing trauma. I don't identify with being an addict or being codependent with an addict, so I don't fit in 12-step, but I'm jealous of the 12-steppers for the community and the proximity to communities of recovery with vulnerability and authenticity. And if I were queen of the world, I would change 12-step altogether because I don't think it's very trauma informed. But I love what it is for what it is and think that the trauma recovery process needs a similar form of community. And maybe at some point, churches or temples were functioning in that way. And that's broken down a lot. And I know in my history, I have total post-traumatic church syndrome that's been part of what I've needed to treat. So the church hasn't felt like a resource for me. But then there's a big void of like, where is the community resource for recovery from the suffering that humans go through? So I'm curious if we missed any buckets or if you disagree or... Yeah.
A couple comments. I've got one new bucket for you, I think.
Awesome.
We'll see. The other piece is that one of the things that we experience in the NARM training, even though it's a professional training, we do our own personal work. And, as Sarah, as you have seen, is that when people are sharing on deep levels of vulnerability, the heart space that opens up in the training groups can be so powerful. And it is a community kind of healing. And there is this developing NARM community. And it's been a paradoxical for me because sometimes I've had a student after a couple of years come up and say, well, can this be done in groups? And I'll say, well, that's really what we've been doing in a certain way. I mean, it's a professional training, but the whole NARM understanding is without your own personal development, you can't really take anybody someplace that you haven't gone to in one way or another to yourself. So I agree that the importance of healing in community, and Thomas has been interviewed here with Sarah and me. And the last bucket that I want to talk about is a project that I'm involved with Christina Bethel, who's also been interviewed here with Sarah and me. And she's a professor of public health at Johns Hopkins. And her whole focus, and I've been enlisted in this thing that she's spearheading, which is relational health, and really teaching and focusing the first, and this is this other bucket, I think, focusing both on pediatricians and primary care physicians on just educating them to become aware of these dynamics, because they're kind of like the first line. They see these struggling families that sometimes don't even know the degree to which they're struggling, and to be able to begin to recognize that. And then the next step will be some of the buckets that I think that you mentioned, Lissa, is that then how, once we've recognized these dynamics and once these pediatricians and other primary care docs are trained in how to at least do a little psychoeducation around it, then we need more advanced and developed ways to deal with large groups of people and make it more cost effective for people so that it's available to larger and larger sets of the population. Because as we all know, the trauma right now, particularly after, it's not even after COVID yet, but, hopefully after the worst of things, is so widespread, as you talked about earlier. So, and I just wanted to mention too, and for our listeners, is that the very first article in this direction is going to be published it's called the Journal of Child and Adolescent Psychiatry next December this year. It's officially coming out in January of 2022, but it should be out in December 2021. And it's about supporting relational health in general, and particularly obviously oriented towards physicians at this point. But the big picture is to make this information as accessible to as many different kinds of, primary care people, including physicians, but also nurse practitioners and, many other professions as well.
So can you clarify, what would that bucket be named?
Well, it's identifying, because you've got all these people out there struggling, and they're often struggling alone. And if they're lucky, or struggling alone, by themselves and struggling alone as a family, then the only way that their first access to help will often be because they're having some kind of physical symptoms.
Yep.
So they go to their pediatrician if the child is the one who's showing the symptoms, or if they're the one showing the symptoms. And if the first wave of providers is not attuned to trauma-informed treatment, then they're going to, as you were mentioning earlier, they're going to miss so much that's important. And they're going to use these basic kinds of CBT interventions, which are a start, but they're nowhere near enough from my perspective. Even so-called trauma-focused CBT doesn't begin to cover the field that we're touching on here. And so finding, other additional resources for.
So would you call it like early intervention trauma diagnosis or something like that? Trauma identification?
Let's change the paradigm.
Yeah.
Deficiency in relational health.
Okay.
Part of the very conscious paradigm shift is to change it, not to exclude toxic stress, which was the original, paradigm that was used, but to shift the direction more towards relational health. And what can we do? And how can we, as a big variety of practitioners, support increasing relational health for all different elements of our population, from rich to poor, and from, regardless of where they live or what their background or what their ethnicity or race, or just to make it as available to as many people as possible.
Right. Well, I've started a nonprofit called Heal at Last, and that's how Chris Rutgers found me, because I was starting to speak publicly on stages and such on my blog before the pandemic. We were supposed to start our first pilot in March of 2020. As you can imagine, that didn't go very well. The idea was to get people together in person, off screens, away from the internet, to sit in a room and have the relational contact while doing, you've read my book, Sacred Medicine, Larry, so you know what I mean when I say I sort of put practices and tools into two categories of trauma supportive practices, which we could think of as like an energy transfusion. If you're anemic on life force, because some people are so anemic on life force, they're not ready to go into old memories that are nervous system dysregulating. And so, those trauma supportive practices might be things like hands-on healing or yoga or dance or singing like kirtan or creativity and art or, going to Lourdes and spiritual pilgrimage and things like that. And then I make that as a distinction from sort of trauma treatment. And both of them would be under the category of healing. And so we're looking to use both those trauma supportive practices and those trauma treatment practices in a group way, by donation only, led by experienced, cross-trained trauma therapists, at least in the beginning.
So the one element that I want to mention, because I think it's so significant, is that part of the adaptation to developmental trauma that people make brings now not just external obstacles to growth, but they develop internal obstacles, so that even when supportive and useful methods are available to them, if they don't understand what if like an energy healer does not understand the internal obstacles that a person is dealing with, they can move their energy around, but the client isn't necessarily ready for that. And for some clients, and I've worked with clients who've been re-traumatized by very real and effective energy work. That was the challenge, is it was effective. And as such, they weren't ready. They didn't know how to adapt to the shifts that were brought externally. And really part of what my focus in NARM is helping people not just deal with the external obstacles. We need to pay attention to, the environment and all of those issues, but also the internal obstacles that we've all developed in our own adaptation to developmental trauma. And so that's why when I teach body workers or energy workers or anybody who's shifting people from the outside in a certain way, I want them to be aware of that they're working with a whole ecological system, including personality, mind, body, the whole thing. And if they change one element, depending on the person and their, window of tolerance, or what we call in NARM, their psychobiological capacity, you can shift one thing, but then there will be another compensation someplace else if they're not paying attention to that. Or it can be too much for them and overwhelming, and that happens as well.
I completely agree with you on that. And I certainly have seen the harm that can happen in the name of energy healing, especially if they're dialoguing with the client. That's what I mean by trauma healing done badly, where there's boundary violations, or a lot of people in that world will identify as being empaths. And I'm trained in IFS, so I'll use IFS language to say, in other words, if I'm working with a client and I can spot your parts, but in the IFS world, it would be an absolute boundary violation to call out the parts that I spot. And a lot of the energy healers are doing that. I can see what's wrong with you. I can see your blind spots. So I'm going to call out your blind spots, and now I'm going to fix them for you. And that, in my experience, there's very often very damaging backlash and re-traumatization and nervous system dysregulation. And sometimes, like at Esalen in the early 60s with the early Gestalt and all of that, there was high suicide risk, high overdose risk. It was quite dangerous.
Yeah. Again, that is so consistent with NARM. It's one of the things that we're always very careful to never interpret, to never tell the client about themselves. We may ask them questions that are based on our best guess or best speculation, our best sense of things at that moment, but it's always done with a certain kind of respect, that it's always a question, and then the client needs to check in with themselves and feel if that's right. So we don't ever take the role of being the expert in your internal world. That's a fundamental element of the NARM work. So, yeah, and Dick Schwartz is another person who's been on this podcast with Sarah and me, and it's another area where I think he and I are in agreement as well. So.
Well, and just to throw in from my student perspective, one of the things that I've learned in my journey with NARM is whenever I have had the impetus to fix a client, it's really coming from my own trauma. And so as you both are talking about this, I'm just thinking about how crucial it is for there to be trauma healing for the healers. I want to say first, but maybe not first, but simultaneously, because if we're just telling doctors, you need to be relational, you need to be trauma informed. I mean, Lissa, we've talked about this on my podcast too. The top-down way that a doctor will take that in might not necessarily translate to what we're talking about here.
Absolutely. I completely agree. Yeah, I'm curious from you guys also. I just had a session done on me. Chris Rutgers wanted me to experience his therapist, who is trained, I think she's trained with in Feldenkrais, and also with Steve Terrell and Kathy Kane in the nurturing resilience work. And I think they came from the somatic experiencing world. And it was very interesting for me, after 10 years of studying energy healing and landing on trauma therapy, to go to this trauma therapist who specializes in developmental trauma. And at the end of it, I said, okay, how in the world is that any different than energy healing? Because she was just putting her hands on me and not speaking, in different parts of the body, and just kind of being present and drawing attention to my own interoception, my own embodiment at the sites that she was touching with her hands. But it made me laugh. I was like giggling afterwards. And I was watching her do a session on Chris, and I'm going, all right, from the outside world, this looks absolutely the same as the energy healers I was working with 10 years ago. And it felt like this kind of full circle moment. Like I went from energy healing to trauma therapy to now a developmental trauma expert who looks like she's doing energy healing. And I'm like, how is this not the same thing? And she said, well, because I'm not doing anything. I'm not fixing your body. I'm not putting chi in. I'm not reorganizing your energetic matrix. I have my hand here and I'm present with you, and whatever needs to arise or move or shift is doing so of its own nature. And I couldn't stop laughing, not during the session, but afterwards, where I was like, maybe there's more crossover there than I realized, especially with the hands-on work. And I'm curious, I don't know how much, if any. I know in your book, Larry, you wrote the book with Aline Lapierre, and there was a teaching of her touch work there as well. Is there a touch element in NARM?
There are people in NARM who also integrate touch. I don't teach touch. The touch work is Aline's own separate work, and she was, the co-author of the book. But that's different from her model, is somewhat different from the NARM model in terms of the psychotherapy piece. But I've known Kathy for at least 30 years, and I think she's incredible. And I also see the limitations of just bottom-up work, and that it's really important to be able to, for many things, to be able to do the bottom-up energy work or organ work or the various kinds of things that are out there. But it's also, at least from a NARM perspective, from my perspective, it's so important to be able to reflect on those shifts top down and the identifications that are being held energetically and in the form of tension and collapse in the body. And that's why I'm very persistent about naming that NARM is both a top-down and a bottom-up work. So there's space to integrate that kind of work, but at the same time, we don't do that just on its own way. There is a certain way that you have to address top-down issues in addition.
I know that's been super helpful for me and for Chris. Mostly in my world, it was from the IFS lens, and from Chris's, it was your lens, because he doesn't know as much about IFS. But both of them, I think, do a good job of that bucket of helping us understand and develop self-compassion for adaptive strategies as absolutely life-giving survival skills when they developed. And, even if we've outgrown their usefulness, to be able to understand that they were protector parts in the IFS world or survival strategies in the NARM world. Having the cognitive understanding of that for me has been incredibly helpful in avoiding sort of shame spirals, or it's really helped me with shame resilience around because if I hadn't had that first, yes, I know for me in my own trauma healing journey, the beginning of my work was often around just developing compassion for myself around the ways that I've been victimized. And the more difficult part of my work was developing compassion for myself around the ways that I've perpetrated trauma to others because of my own developmental trauma. And that's much harder part of the journey. It's much easier to feel like, poor me, I'm the victim. I can have pity on myself. Okay, well, I can have compassion for my young, vulnerable, wounded parts. But it's helped me to understand those adaptive strategies, to realize that even the ways in which I've perpetrated harm, while, yes, I must be held accountable for those ways, it's important to make apologies and make amends and make repairs and make changes in my behavior. And that's my responsibility. But there's also an element of harmlessness of, well, it wasn't my fault. It was my mother's fault. Well, it wasn't my mother's fault. It was her mother's fault, or her father's fault, or the generational kind of viral nature of these sorts of developmental traumas can allow us to have both accountability and a kind of harmlessness or self-compassion for why we do the things that we do, even if they're self-destructive or destructive to other people. And so for me, that's been the helpful part of the cognitive understanding.
Yeah, and I'd like to just emphasize that last point that you made, which is that it's not just the trauma that then we pass on to other people, but how we've internalized what I talk about in NARM as the environmental failure in the various forms that took, and continue to perpetrate it against ourselves. And that is also part of the survival strategy. And it's one of the things I try to teach in the trainings is that there is a limit to so much compassion that you can nurture in someone else until they get to the point where they have to look at why they were shaming and rejecting and hating themselves in the first place. Because I'm a big, and of course the mindfulness perspective is to support compassion. I'm fully on board with that. And I've seen the limitations of that when it feels life protective to a person to hate themselves, to reject themselves. That piece needs to be addressed. And that, in the NARM language, is always coming from child consciousness, usually has to do with trying to protect the attachment relationship, the love relationship. So turning against the self, as children tend to do, to protect that relationship. And that, for me, has been a key that I've been trying to address in so many different ways. And that's one of the things that when you use traditional bottom-up methods that don't address that dynamic, I think you're missing an important piece. And I think that the therapist will eventually get stuck because the client can only go so far with the bottom-up work that they're doing. That's also a distinction I make with shock trauma, because shock trauma, theoretically, when it's not evoking all kinds of developmental trauma, is primarily a bottom-up process. That really is a physiological fight-flight dynamic and the completion of fight-flight. That makes sense with shock trauma. but you can't deal with self-hatred in the same way that you deal with, the sequelae from a car accident, for example. It's a very different emotional and identity dynamics that need to be incorporated into the energetic and the body-based work and the bottom-up work that we do.
Well, I really value the work that you're doing in that realm. That was really helpful to the healthcare providers in my program, the Whole Health Medicine Institute, when you were teaching them. That idea that we had to, in child consciousness, turn against the self as a way to protect the attachment to the unhealthy adult was a huge epiphany. And there was a lot of unpacking and processing of that afterwards in that group. So thank you for bringing that piece in. And it brings me to a question or an inquiry that I've been in deep process with while I was in Hawaii over the past 2 weeks for my first pandemic holiday while leading this retreat for the healthcare providers I was staying with one of the doctors and doing this retreat on Zoom. And an inquiry that was coming up with one of my dear friends who is a psychiatrist. We were having a whole conversation about forgiveness in the trauma healing journey. Like when we have been victimized by trauma in the family system, for example, or victimized by somebody in the outside world, let's say a Holocaust survivor that's victimized by, the Nazis. We were trying to have a trauma-informed conversation about forgiveness, which, having come from the church and experiencing post-traumatic church syndrome, I know in the church, for example, these sort of lessons in radical forgiveness were kind of crammed down my throat and sort of hammered into me in a way that I was so young that it basically groomed me to tolerate abuse, such that in my medical training, for example, I was the victim of multiple episodes of criminal assault. Like I should have called the cops level of assault. And it's very, very common for female physicians, female medical students and residents to be victimized by either criminal or sexual assault by their teachers, by the residents and faculty that are above them. That is, having worked with doctors now for 8 years, I can tell you, and most of them are female, it is almost ubiquitous. Almost every one of us, at least in the surgical specialties, have been the victims of something that was an actual crime. Like in my case, it was getting HIV-infected scalpels thrown at me if I got the answer wrong when I was asked an anatomy question in surgery, or being stabbed with HIV-infected needles. Like that level of criminal assault, not to mention incredible levels of sexual harassment. And so I'm curious for trauma survivors, because this is something that I've been in inquiry around, is like, what is healthy forgiveness of the other? Because what I'm hearing here is there's a split in this child consciousness around this turning on the self in order to sort of forgive the other, the adult. And as we become adults and as we're sort of healing these, how do we come to a place of like, what is real forgiveness? I'm curious if you have.
I do. It's actually an important point for me, and I do have a strong opinion about it.
Yeah.
One is that forgiveness cannot be legislated. And it's not just the church that tries to jam it down people's throat. There's all kinds of new agey or, those kinds of things that have the same kind of dynamic. I had a client once who was severely sexually assaulted. She went to her spiritual teacher. Her spiritual teacher said, "Have you forgiven him yet?" And, this is so wrong. And at the same time, forgiveness can happen, but it has to happen organically as the individuals work through the various unresolved emotions about that. And forgiveness for me is one of the many heart states that people access as they do their work. And that can be very real. And when people come at that from an organic place, it's not forced, it's not pushed, they're not thinking their way into it. It's there because the heart is opening. That in itself brings so much systemic change. And now I'm talking about the personal system, but the bigger systems as well. It has impact on the larger field when people are coming from that authentic place of forgiveness. And it takes work. There's no quick bypasses to forgiveness. And when people think they are, I think they're often doing harm, actually. Then,
yeah, the sort of spiritual bypass.
The spiritual bypass, exactly.
Yeah.
Well, I feel like we could go on for so long, but I'm very conscious of time right now. But Lissa, I want to give you an opportunity to share, how can listeners find out more about you, your work, your writing, and everything?
Oh, well, my main website is my name, lissarankin.com, LISSARANKIN. And that has links to the Whole Health Medicine Institute, which we just closed enrollment. So that won't be enrolling until next year. But we do have an ongoing continuity program called Healing with the Muse, where we're doing these trauma supportive and trauma treatment. We've actually taught your work, Larry, in that community. So we're trying to cherry pick some of the best trauma healing tools from the different model builders who are all offering such amazing cutting edge tools for things that are actually working. So we're trying to stay on the edge, the cutting edge of the traumatology field, while also doing things that make it a little bit lighter, singing and dancing and doing sort of virtual cuddle puddles and making art and writing and, processing in groups. And that's called Healing with the Muse. Yeah. And I have 7 books that I'm working on and working on an 8th. And those are all at Amazon. You can find them all on my website. I also write almost every day on Facebook. At my public page is Lissa Rankin. And that's been really amazing this year because I had to get very boundaried because of the nature of this past year and the polarizations. So it's been wonderful to be able to crowdsource the community. I can't remember, Sarah, if you've been part of that, but we've had some amazing practitioners that are really trying to solve some of these problems, which I'm amazed to say that that's happening on Facebook, like to pose an inquiry about what's working and to actually come up with solutions. So that's been really fun.
Mm-hmm.
Yeah.
Well, Lissa, I can't thank you enough for being here today. And Larry, as always, we really appreciate your time. And I'm so excited for listeners to hear this.
Oh, thank you.
Great to be here with both of you as well. Thanks.
Thank you so much, both of you.
Thanks so much for joining us for today's episode. To find more about our guest, check the show notes or visit us at www.narmtraining.com/transformingtrauma. The NARM Training Institute also offers the Inner Circle, an online self-paced learning program intended for anyone who is interested in joining an international online community focused on healing complex trauma. You can find more information about these trauma-informed learning programs in addition to other resources on the website, www.narmtraining.com. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Tori Essex for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.